Our last speaker for this setting is Dr. Oron Frenkel. Oron completed his residency in emergency medicine and then did a fellowship in point-of-care ultrasound down in California. He moved to Vancouver in 2015 to escape the gun violence, work under a single-payer system, and help bring point-of-care ultrasound to the rural West Coast. He's now the director of the PoCUS program, point-of-care ultrasound program in the emergency department at St. Paul's. Teaches as assistant clinical professor at the university and helps to run the PoCUS fellowship and elective program based out of St. Paul's. He's working toward creating creative solutions for spreading ultrasound use. He's a very engaging speaker, and I'm hoping he's going to come up. Come on up, Oron. Kevin, yeah, I'm done. Yeah.
Hi, everyone. Thanks. My topic, slick tricks with the PoCUS probe. I didn't choose it, but I'll take it. So I have no disclosures. My objectives are 3 slick tricks. So I figured you guys would be bored with the one objective that's in the syllabus of just fascia iliaca blocks. So we broke it up into 3. Some of you may already do some of these things, and for you, I have piles of pearls to make you even more effective. For those who have never heard of any of these, you'll learn something. The goal is to entertain and maybe take something to your next shift. But really what we're going to do is we're going to do these slick tricks. You're going to impress your colleagues, you're going to look good doing it, and hopefully you'll do good for your patients. So, slick trick number 1. This is the experience of a lot of patients who have broken limbs in our emergency department. Every time we move them to do their imaging, to take their x-rays, especially our little old ladies with broken hips, or in the trauma bay, people with a broken femur, they really don't like being moved, and yet we persist in moving them around to do everything we have to. So how can we do better? We have our patients who took a fall and broke their hip, broke a femur, and I want to expand also your thought process when I'm going to talk about the femoral block on think broadly outside the box. Maybe you work in Australia and you see a great white shark attack, or anyone who really has pain in their leg and needs a lot of help, think about the femoral block. So the thing that I want you to pay attention is the nerve goes to, we always learned about the dermatome, but there's also the myotome and the osteome, right? So these are the things that each of these nerve complexes will innervate, and you can get all of them with a single nerve instead of just the parenteral analgesia that we usually use. For hip fractures, we have the best data on using it in the emergency department. When the Cochrane review says that we should be doing something, I think we all should be doing it. So for our little older patients who have broken hips, we know that we can improve their outcomes by giving them a nerve block in the emergency department. Early on in their course of stay, it really determines a lot of their outcome and future experience in the hospital. So it's not just the pain and someone whipping on them and beating them as they move them from gurney to gurney and on the saver into the x-ray and whatever else they need, but it's also down the line as they go to the OR and beyond that nerve blocks early on in the trauma setting and the emergent setting can really improve their outcomes. We also think that not just from pneumonia, why do you think they get pneumonia? Because we're giving them lots of opiates to keep them calm and quiet, and now we're depressing their respiratory rate, there's aspiration events, and then we also think from the case experience of people who are actually doing this that there's much lower rates of delirium, right? You don't have to keep giving hydromorphone or morphine to our older patients who are going to experience the, extra effects of the drugs that we're giving them, and beyond, maybe even death. So they may even experience lower mortality, but we don't have enough numbers to prove that. And so how are you actually going to do it on your patients? It's going to be a lot like a femoral vein catheter if you put it in. So we go right below the inguinal ligament. And we're not going to go, I'm going to show you one of my slick tricks is to move beyond where you would go blind. So this is generally where you would go blind. We remember nerve, artery, vein. And so we're going to bring the ultrasound in, and we're going to do this even slicker. Okay? This was an American problem. I haven't seen it as much in Canada, but when you have your large BMI, what are you going to do to get access to the groin? Whether you're putting in a femoral line or you're doing a femoral block, you can tape up the pannus. Works pretty magical. There's a slick trick for you. Okay, now, so in the anatomy, what's important about knowing how to do this block is that you actually have to get through the 2 fascial layers that protect the femoral nerve. So the femoral nerve sits actually in the iliopsoas muscle. So what we have is we have the fascia lata, which is up top. It's usually very easy to see in patients, but then you also have the fascia iliaca. And this is the one, if you don't get the anesthesia deep under the fascia iliaca, your nerve block is not going to work. So that is the key point of getting this as an effective block. And it's where ultrasound really comes to save you, to show you your anesthesia going under the block. Let me show you what it looks like. Before we get there, though, the slick trick is to use saline. So we're trying to find a fascial plane. We don't want to go in with our anesthesia, right? Our older patient maybe weighs 50 kilos. It doesn't give me a lot of bupivacaine to work with to do my nerve block, right? I want her to feel good pain relief for 12, 24 hours down the line. If I'm wasting my anesthesia going in trying to find this fascial plane, I wasted a lot of it where it's not going to work. So I'm going to start with saline. And the way I'm going to do it, I'm going to take a big syringe with some extension tubing. And if you don't have block needles, you can use, the way I'm going to show you to stay safe, is you can use a regular spinal needle here, because we're not going to go anywhere near the nerve. And what we're going to do is you come in. This is what it looks like on the ultrasound screen. We're going to get through that top fascial layer, easy to see, but you can notice this, there's all these lines. Which one is the fascial layer, Frenkel? Which one am I supposed to go below? I don't know, I'm just starting to inject. So you can see you have your saline loaded in your syringe, and you can test dose. So you have someone helping you, or if you're super slick, you can look up a YouTube on how to do it one-handed. But either way, you do it this, and you can keep adding and advancing the needle to inject saline until you can see that you're really under the fascia. And the way you know you're under the fascia is it starts spreading towards the vessels, right? Our vessels are right over here, and here's our femoral nerve. So now I know that I am in the right fascial plane. I'm lifting the fascia off the psoas muscle. My saline has opened the space. Now I switch the syringe. In comes the anesthetic, and I dump it exactly where I need it. I know it's in the right place, and boom, I walk away, give some high fives. Okay. The last part is how do we do this and stay safe? People are always, I'm really nervous about the vessels. I'm really nervous about puncturing the nerve. So we don't have to go anywhere near the nerve, right? The ultrasound helps us turn this as a fascial block so I can actually stay away from the nerve, right? I showed you this picture earlier. Here's our vein, artery, and the nerve. I'm going to inject way out here on top of the iliopsoas. I don't need to be a block jock like my anesthesia colleagues and really hit the femoral nerve. I can go way out here, and what I'm going to do is inject far enough with enough volume that the anesthesia will spread not only to the femoral nerve, but it will also track up that fascial plane and get the other two nerves that innervate the hip, right? They called it a 3-in-1 block. So we turn the femoral nerve block into a fascia iliaca compartment block. The same approach with a bigger volume with ultrasound, right? So this is what it's going to look like. Here's my needle coming in. I'm going to test it out, and I'm going to know, see, there's my test dose. Here's my real dose. Oh, boom, I'm in. I see it spreading, right? And my nerve is way over here. So my needle tip, you know, in ultrasound world, this is like a centimeter, but I can see exactly where my needle tip is. I'm far from puncturing or injuring that nerve. There's nothing else around that I'm going to hurt, and I can dump in my 15, 20 cc's of anesthesia. So how much anesthetic? It has to be a big volume block, right? It's not going to work if you block jock it and just try to hit the femoral nerve, right? We're talking 15 to 30 cc's. So you have to do your math. You have to calculate backwards, how much anesthetic can I give this 50-kilo older woman? So don't cause LAST, right? LAST is local anesthetic systemic toxicity. You don't want to be that person. And I don't want to be the person who told you to do the block and then you're the person who gave someone LAST. So they need to be on a cardiac monitor, right? Everyone who's getting this volume of block should be on a cardiac monitor. The good news is our patients who have femoral fractures, the patients who have hip fractures who are getting admitted, they're already on a monitored bed usually. So that keeps it pretty easy. The second is that you should probably have intralipid in your emergency department if you're going to be doing big volume, long-acting anesthesia blocks. It's debatable whether it actually works, but it looks good in case you need it, and there's a problem that at least you had it. And really making sure you have the right dose is critical to doing this properly. Okay. Last, I'm going to throw in here, say you have your shark attack patient, or like what we saw in Oakland, someone got shot in the leg maybe a couple times. And they're really angry, right? They're screaming. There is no amount of fentanyl that's going to calm them down. They're in so much pain. So in comes the ultrasound team. The femoral block goes in, and they go apneic, right? Because suddenly they can finally breathe an air of relaxation. The block is working, and now they have 600 micrograms of fentanyl in them. and they are apneic. So you have to think about it early in the trauma setting that if you're going to do a block, get it in early. It will save you the anesthesia or the opiates you're giving afterward if you're in the proper setting, but it helps you just think ahead. And it's something to watch out, especially on your little old lady who now has 20 of morphine on board, and now you do the block, you walk away, you know, she's might desat. So just be careful, okay? All right, slick trick number 2. Is it in yet? My wife tried to censor the video, I didn't let her. Okay, so here's your patient. They come in, maybe they jumped off a bridge and their shoulder hurts after they did a giant cannonball into the river, right? Okay, maybe they don't like this, they're holding their arm more like this, but I couldn't find the right photo. So you get the x-ray, you see it's dislocated, yeah? It's pretty obvious. So now what? Standard is, well, we'll do maybe, you do your tug, do your Cunningham, do whatever maneuver you want, maybe, and then there's the question, is it in? It's even worse if you go to procedural sedation and x-ray is far away, you do the propofol, there was no satisfying clunk or click, and then there's always the question, is it in, right? And you're starting to feel, and you can't really tell, you sweat a little, everyone's wondering, and you're like, I don't know, they need another x-ray. And then off they go to x-ray, and then what if it's not in, right? You just kind of wasted your propofol, you wasted your sedation. So, never trust a study that claims 100%, but it's pretty good. It's still got to be something close to that, right? It got in annals. So it's the accuracy of ultrasound, and I'll show you it's actually quite straightforward to diagnose shoulder dislocations is very straightforward with the ultrasound. You're going to come from the back, below the scapular spine, right? Ultrasound in front, and we're just going to slide over from the humerus, and I'm going to come over, and can you see my little cursor? Is it way off? Oh, there it is. Yeah, good. And what I'm seeing is the glenoid fossa, and I'm going to see the humeral head articulating with the glenoid fossa. Okay? So I'm right below the scapular spine, posterior approach. One slick trick, you can pick up your early posterior dislocation, right? The textbook is always that you're not going to see it on the plain film, although frequently I don't know how many I've missed because I don't know, I didn't see them not get it on the x-ray. But if you pop it on and diagnose with the ultrasound, you'll see an anterior dislocation of the humeral head past the glenoid fossa, or you can see it actually posterior moved closer to your transducer in a posterior dislocation. Okay, here's another slick trick, if you've already known this one, is to put local anesthetic into that glenoid fossa with your ultrasound, because you already have it there, and get great anesthesia to the shoulder. We've watched them relocate themselves after you put the anesthesia right into the shoulder capsule. So how do you do it? One main thing, this is a spinal needle. If you're not using a spinal needle to try and do this, you are not entering the glenoid fossa. Okay, it's a lot deeper than you think, and because we're going through the deltoid, this isn't an attempt at a shoulder injection from the back, which probably still doesn't work with a normal needle, but we like to think it does. But you definitely aren't doing it if you're not using a spinal needle from a lateral approach. And I'm using it in the same way. I have my ultrasound, I see the anteriorly dislocated humeral head, I can watch my spinal needle come in plane, right into the glenoid fossa. Yep. And then what freaks you out in this picture? Two things. First, they're not wearing gloves, so we kind of photoshopped it in. This was one of my co-residents. I'm like, what are you doing? We need that photo. But we had to fix it anyway. Okay, second was that there's blood in the syringe, right? So usually you don't like to see blood in your syringe when you're doing any injection with local anesthetic, right? That's the rule. Aspirate, make sure there's no blood, inject. So just like a hematoma block, though, that's kind of what we're doing. We're going into the socket you're in when there's blood, because after that humor is dislocated, the fossa is full of blood. And this is what it looks like. So here's my glenoid fossa. Here's the humeral head. It's anteriorly dislocated, so it's further away from the transducer. Okay, and here it comes in. Here's my needle. Notice how long it is. And as I'm injecting, I'm watching in real time. There's my anesthetic swirling around in the glenoid fossa. Psh, money. All right. So when Jamie comes knocking and wonders if it's in, you can tell him, yeah. Okay. So my last slick trick, I'm just going to blow through them. Your no-fuss central venous catheter. What do I mean? I mean, this is our normal experience that we've all trained to do ultrasound-guided IJs in particular, right? Here's my view, transverse. I have my needle in. Okay, and I'm going to point out some problems with what's about to happen. So flash is in. Got the flash in the syringe. First thing, ultrasound probe's down. Bad news, okay? Bad news. Never put your probe down. But you do anyway, right? That's what we're trained to do, is we're trained to just drop it on the patient, right? Move on to the next phase. Bad. Okay, second. Now, I got my flash. I'm turning away. What? His hand just jiggled. The hand just jiggled. What's going to happen now? Who knows if he's in anymore, right? Are you waiting to see the blood keep coming? If you're lucky, you see blood keep coming the whole time. Hopefully it's not squirting over your shoulder, right? That's the other problem. And then he goes to put the wire in. It doesn't go. The wire's not going. So now what do? Do you blindly redirect? How many would blindly redirect and just try again? Some of you would. Okay. Then who takes the syringe and then tries and does it over? Keeps going in and out with the syringe, going, see if I can get it. The ultrasound probe is still draped over the person, right? You're not picking it back up. Or you really sigh, and you squirt the blood out, wash it out, and then you just put the probe back on, try it again. The same thing you just did, right? Isn't that like the definition of insanity is when you do the same thing twice? So let me show you how to do it better. First of all, what's different about this picture? There's no syringe, right? There's no syringe. So we're going to take the wire and we're going to preload it into the needle. Just the needle, no syringe, okay? And what I'm going to do is I'm going to see the little, I don't know if you can see it up there, you see the little J hook come out? And I'm going to pull the wire back just so it's just inside the needle, okay? So the wire is in the needle, but it's just behind the bevel. Preloaded. Second, this comes naturally to Americans. I appreciate maybe it doesn't to Canadians, the gun pistol grip, right? So you got to hold it in place. Now, there is a problem, right, that this kit is not made to do this. So, this kit is not made to really do this. So you're going to have to hold the needle on. I've seen and heard of people doing the trick of cutting, but there's no scissors in the kit, so no one wants to fuss. So you just have to hold the needle in place. And you guys, there's one of the catheters out there you can play with. And you hold it in so you can do the pistol grip, one hand with the wire in the needle and hold it all together. Okay? Right? And this is important because you want your thumb free to be able to feed the wire. Right? So you're holding the needle and ready to feed the wire at the same time. Okay? After you're holding it right, you have your proper grip preloaded, you're going for the wire and needle. You're going for the win. So this is what it's going to look like on a model, right? And I'm going in plane. So I have my IJ in plane. I'm watching my needle come in the whole time. And in one motion, needle's in, wire in, right? So I am confirmed. Wire is in the IJ. There's no syringe. There's no turning. There's no fuss. There's no blood splatter. The ultrasound doesn't go down until the wire's in, and I can take my breath, cut, dilate, catheter, right? It's pretty slick. This is what it looks like on a real person. Same thing, right? He's got the pistol grip here, and it's going in, and wire in. Boom, go for it. Okay, now, what's even greater, you have your ultrasound already there. So no talk is done. I have to really exploit and maximize your use of the ultrasound in this situation. So you have the wire, we leave the probe, right? Now you cut, dilate, catheter. Okay, is the ultrasound in? Is the line in the right place? Did I cause a pneumothorax? Well, if you did the wire and needle and you were confident with where everything was, probably not, right? But your best thing to check, why not just look for a pneumothorax, right? You already have the ultrasound out. You can take a quick look on the right side if you're just putting it on the right side and confirm you didn't pop the lung. So it's actually quite good, right? In systematic review, again, don't trust the 100% number. But the problem here is that we already knew ultrasound was better than chest x-ray. That's a whole separate talk. But we know it's way more sensitive for pneumothorax than a chest x-ray is going to be. And yet we still rely on the chest x-ray for a pneumothorax. So your ultrasound is going to catch way more pneumothoraces if you just kind of pop the lung a little bit than your chest x-ray is. So we already know it kind of outperforms. So you really, I think, can trust this data that it's going to tell you there's no pneumothorax when you nailed it. And then even cooler, because maybe you already do that. Maybe you're that good. Then you can really impress your friends and do a bubble study. Okay? So you just put the catheter in the IJ, grab a preloaded syringe with saline, and just shoot it in the line. You're pretty sure it's in the right place. What's going to hurt if it's in the wrong vein, if it went across, or if it went, we've seen them go in the other IJ. You're pretty sure it's not in the carotid, but even if it is in the carotid, you squirt some saline in, and then you look subxiphoid at the heart, and whoosh. Right? Great. High five, central lines in place, hang the pressors, we're ready. Right? All pretty quick. You just confirmed you didn't cause a complication. You confirmed the line's in the right place, and you know it's ready to use. Before you even had to call your x-ray tech, who's going to take 15, 20 minutes to come, depending on where you are in the hospital. Right? And because everything's been studied in ultrasound at this point, these are residents, right? So limited training. I love it. Like they didn't really do very many before they're like, okay, I'm ready to try this. I tried it at home and now I'm ready to try it on my patients. So, and when they saw that rapid atrial swirl, it confirmed that the central line was always in the right place. If you don't see the swirl, you have to wonder. These papers, they actually just, the main complication was it went across to like the subclavian on the other side. It didn't actually go anywhere wrong. It's just squirting the saline not exactly where you want it. But if you see the swirl, the line is in the right place, it's going where you want, and it's all good, ready to go. All right. So, slick tricks for your next shift. Whether you have never seen any of these before or you're ready to try something new, femoral fascia iliaca compartment block, turn your femoral nerve into fascia iliaca compartment block, large volume, stay away from the nerve, and you'll be safe, and it's a logical thing to do. Okay? Shoulder dislocation, you can diagnose, anesthetize, and confirm your relocation all in one go while you're there without even the x-ray if you're feeling that good. And then you can go for the win on your sicker patients with your central line, put it in, ditch the syringe, and then confirm your placement and your wire and no complications. I want to thank everyone who provided some extra content for this, and his videos I used in a lot of the video, in a lot of the presentation. And then if you want to learn more about some of the things, this is a site I just want to advertise. CPD has put a lot of, UBC CPD has put a lot of effort into building this website. There's a lot of like quick, slick, trick things on there as it's supposed to be a quick review, so we designed it so that it's 30 seconds for you to look at and get tips on different topics you need while you're on shift or actually at work and don't have time to read about things, but maybe you learned it before. And that's it. I'm ready for questions. No.